Now I'm going to discuss data from the phase 3 INVICTUS trial, which led to the approval of ripretinib in fourth-line GIST. The study was a randomized multi-center study where 129 patients were randomized in a 2:1 fashion to either receive ripretinib, 150 milligrams once daily, or placebo. Patients were imaged initially every 4 weeks so we could pick up progression early in especially the placebo arm. And once they were unblinded at the time of progression, if they were on ripretinib, they had 3 choices: either to continue the same ripretinib dose if the physician thought they were deriving clinical benefit, or if they felt they could tolerate it, they were allowed to escalate the dose to 150 milligrams BID, or discontinue based on investigator or patient choice. If you were on placebo, you had the option to cross over to ripretinib 150 milligrams once daily. So these patients were followed, and the majority of the patients on this study were heavily pre-treated. There were some patients in the fourth-line setting, but many patients had received up to 7 prior lines of therapy. Patients were on a wide range of primary mutations, so they did look at the primary mutations on their archival specimens that were available. And the study also involved collection of liquid biopsies, though we don't have that result yet in detail. Now, for most patients, majority of patients on this study did have a KIT mutation. A minority had, a few of them had PDGFR mutations, and for a few of them were wild type, and a few we didn't know the status of their mutational status on baseline. The results of the study showed a statistically significant improvement in the progression-free survival for patients who received ripretinib versus placebo, which was the primary endpoint. It was 6.3 months for patients on ripretinib versus 1 month for patients on placebo. So basically, at the first scan time point, most patients on placebo were progressing. And this is quite classic for patients with GIST. When you remove TKI therapy, or especially beyond third line, these patients tend to do very poorly. So a 6.3-month progression-free survival benefit on the ripretinib arm was quite impressive. The response rate showed that 9% patients on ripretinib had a RECIST response by blinded independent central radiology review, and 0% patients on placebo had a response. This also translated to a survival advantage, whereas patients on the ripretinib arm had a median overall survival of 15.1 months compared to 6.6 months on placebo. So, this data was very encouraging and led FDA to approve this drug not too long ago for fourth line and beyond patients. They did not require a baseline mutational testing, so patients with all mutations in the fourth line setting, in the absence of any other agents, are approved to receive ripretinib and are likely to derive benefit from it. The other important thing to know with new drugs is their safety profile. What's interesting is most patients who have received sunitinib and regorafenib in the second and third line setting, when they switch to ripretinib, they actually do, most of them will notice an improvement in some of the symptoms, especially the hand-foot syndrome. So patients with ripretinib do have palmoplantar erythrodysesthesia, which is what we call the hand-foot syndrome symptoms, but they're usually much milder than what we see with sunitinib or regorafenib. So most people are good at managing side effects with the previous well-known TKIs, and I usually tell patients to continue moisturizing their palms and soles well, and I've not had to do a dose reduction for PPES in patients with ripretinib, but just local management. The other very important thing to counsel patients with ripretinib, what was seen on the study, was a little over 50% rate of alopecia. So unlike other TKIs, where some of them you'll see a change in hair color, with ripretinib, patients do end up losing their hair. Most of them, sometimes it's hair thinning, but a lot of them will have hair loss. Now, I would say for most patients in the fourth line setting, they usually don't care so much about their hair loss, but for a lot of patients, and especially female patients, it is a big change. So it is important to counsel them upfront about this side effect that they might experience, and give them adequate resources in order to manage it, whether it be a wig or what we call a cranial prosthesis, or just advise on how to approach this. You could also send them to a dermatologist, not only because of the alopecia, but there is another side effect that that should be monitored, is development of skin lesions that rarely could be precancerous or cancerous. There was a slight increased incidence of squamous cell cancers and even melanoma that was very minimal. But for most of these patients, I do recommend following with a dermatologist at the sign of any new lesions, and they should at least get a yearly skin exam by a dermatologist. In addition, the other side effects were actually quite similar to what we would see with say, imatinib. There is some fluid retention, some myalgias, but not much. In general, the grade 3 or 4 toxicity actually profile was not very different from placebo. So unlike sunitinib and regorafenib, most patients at the starting dose of 150 milligrams once daily were able to tolerate the drug well, and only 7% needed a dose reduction. So with this drug, I usually start at dose. And again, if they progress, I have dose escalated as well, and they have tolerated it well. It's important to just keep track of these side effects and know it. Another one is high blood pressure, which we're used to monitoring with the sunitinib and regorafenib. It's actually much less common with this. So sometimes you might actually need to reduce their antihypertensive dose that they're on, but some patients might have an increase in blood pressure if they haven't seen that with the previous drugs as well. So it needs to be monitored. So with any new TKI, it is important to follow lab parameters, and I usually do them every 2 weeks initially for the first month or two on ripretinib, and then you can switch to every month thereafter. It's important to follow for anemia, the liver function tests, but the most common things that are seen with ripretinib are really a decrease in phosphorus, and an increase in lipase. Again, the clinical significance of these are not very well known because it hasn't been linked to an increase in pancreatitis, but it's important to follow and recognize that this can happen with ripretinib. Of course, for low phosphate, you replace it as you would with any other therapy, and then just follow the patients to make sure they're not developing any other concerning symptoms. The other finding of importance that came to light with INVICTUS that we all knew was patients on placebo actually don't do very well. So you do want to make sure patients with GIST who are progressing get exposed to as many effective or active lines of therapy as possible, and don't get too much of a break between each of these TKIs because they could rapidly decline in their clinical and performance status. Some of this data was available through the quality of life parameters that were collected on the INVICTUS study. With the virtual ASCO 2020, 2 abstracts were presented, one showing that though patients with ripretinib did have, a little over 50% rate of alopecia, and the palmoplantar erythrodysesthesia being a little over 20%, over time, the effect of these side effects on their quality of life was actually minimal or decreased over time. The other thing that was important is patients on ripretinib kind of were able to maintain their quality of life, their quality of life metrics that were collected with 2 questionnaires, looking at the visual analog scale, and also then looking for their role of their physical function in their daily activities. And that showed that on ripretinib, it was stable. There was slight improvement, but the numbers were not significant there, but at least it was stable. But patients on placebo noted a decline in their functional status. So again, important not to take too long a break, and knowing that there is a 4th-line therapy available so patients can switch if they're progressing on the 3rd-line therapy. It's also important to recognize the mechanism of action of ripretinib is a little different than the previous TKIs. So this was a drug specifically designed to target these driver mutations, and it is what we call a switch control inhibitor. So in GIST patients, most of the mutations are, most of the secondary mutations will be seen in the ATP binding site, which are the exon 13 and 14 mutations. And also mutations are seen in the activation loop, which is exon 17 and 18 mutations. And some drugs effectively target one or the other. Ripretinib basically can bind to the switch pocket, the ATP binding site, and also connect to the activation loop, and it's kind of locks the molecule in the inactive position. So it's a type 2 inhibitor that locks that in an inactive position, so it doesn't let the activation loop swing back and cause the transcription for downstream factors in KIT and PDGFR.